So hemoglobin levels, the things I started to try to talk to about oxygen delivery and stuff, they are not a decent surrogate for how much oxygen is getting to your tissues. But what do 99% of physicians use to do the triggering of when they're going to transfuse? They use a hemoglobin level. It's a perfect disconnect between physiology and reality and behavior. So, as I said, the transfusion happens when the doctor gets uncomfortable because you don't have a little pop-up thing on you like your Thanksgiving turkey that says, hey, I'm done, take me out right now. You just don't have one that says, I'm ready for a transfusion. And transfusion behavior is culture-driven, and this culture doesn't change quickly in medicine. Transfusion research has a tremendous conflict of interest. Why don't we know when to transfuse? Because blood utilization has never undergone FDA efficacy and safety trials. Every other drug has. Blood transfusion is the number one or number two physician intervention in patient care in the United States, and that's never undergone independent testing. So it's totally culture-driven, and it's driven, and we're now finding things out like the risk of infection. That immune suppression, if you get my blood, you will be immunosuppressed to the point that your chance of having an infection after surgery is 300 to 500-fold increased. Wow. Not something the American Red Cross wishes to put on in the Chicago O'Hare Airport. But this is the truth, is that they have driven down, the blood bankers have driven down AIDS and hepatitis dramatically, so that those are not risks you and I need to worry about. The physician decision is a real conundrum, and it's absolute confusion. When do I give a unit of blood? What should I do? There's people like me who are viewed as zealots by some people, and by others as, ahead of the time, trying to push it and make it happen. But in medical schools today, you have 1 hour of teaching time for blood transfusion, an entire medical school curriculum. And what do they talk about? ABO, RH, histocompatibility, and how we test, things that were discovered in 1900. There's not a single bit of teaching about patient blood management in modern-day medical schools. And where do physicians learn when to transfuse, when not? They learn from the gray-haired old men. And most of the gray-haired old men have learned it from the last gray-haired old men. So it's the sheep leading the sheep down right over the edge of the cliff. So on and on we go. And few of them know about the nuances that you heard tonight. We heard about anemia. Here's all kinds of diseases that have anemia. If you don't have anemia, how often do you die? If you do have anemia, and then if you have anemia and the cardiac disease factor going with it, your chance of death goes way, way up. But there's not a shred of evidence that transfusion reduces any of that. Yet, every physician believes in his heart that if they take care of the anemia by giving the transfusion, things will be all fine and better. A huge disconnect and a huge worshiping the wrong thing in the wrong way. And I've coined the term internationally that transfusion is a religion, and it fits every definition of a religion. It's not proven. You can't prove it scientifically yet to date. And God knows if something goes right in that religion, the chorus gets up and sings and everybody dances around. But if it doesn't, or if you are one of the guys like us who are up here today talking, then you're attacking the dogma, and that's heresy, and you can't do that. So it is absolutely a religion, and the same sound bites today in the public relations campaign are the same sound bites that we heard in the 1600s for bleeding patients. So all we've done is trip things around from here we're going to bleed you in the 16 and 1700s into today where we're going to give you a blood transfusion. So physicians, the name physician comes from the old, from leeches. That was the original word for the name physician. Come to find out, 60% of patients who are transfused in intensive care units are transfused because they become anemic because the physicians take out so much blood that they're trying to test for day in and day out. There's new data that shows that if we really truly limit how much blood we do for testing, for all the blood tests, all the times they're sticking you, we can reduce your chance of becoming anemic in the ICU dramatically. So that's a huge challenge for medicine in the future. Big conundrum is what are we doing iatrogenically to make that happen? I'm going to take a couple minutes to talk about TRALI. TRALI stands for transfusion-related acute lung injury. That's this thing where your lungs fill up with water. And here's the conundrum, again, for physicians, which is that if you read the latest research papers, and I'll show a couple of them to you, it says that the incidence of TRALI is 1 to 8% of all patients transfused. That's huge. That's not 1 in 2.5 million like AIDS or hepatitis. But if you read what comes from the American Association of Blood Bankers, they say that the risk is the lowest it's ever been, and it's decreasing tenfold. So if you're an average physician trying to work in this space, who do you believe? Which group of data do you read? And then there's the data about just how many units of blood are we giving. This is data that actually was published by the American Association of Blood Bankers, and for the first time in the history of America, we dropped our utilization of blood. And what did they say was the cause? Because we had an economic downturn. You can go on their website, and that is actually what they say, is we don't understand how the economic downturn caused the Americans to use less blood, but then they say maybe it's patient blood management, and this is a problem for us, we need to manage it, and they got into the space to control the message. So the conundrum is what's really happening out there. Transfusion practice is bizarre. These are different hospitals, 18 different institutions, utilization of blood. One place nobody gets blood, another place 89 or 90% of people get blood. It's a culture. So what does that say to me? That says to me that we as physicians don't have the foggiest idea what we're doing, and we're doing it to you, the American public, because we don't have any data, and we're being driven by belief systems, a religion. Are you a believer or are you a non-believer? And in Jehovah's Witnesses, here's data that has just recently come out that the Jehovah's Witnesses do so much better than patients who the physicians are allowed to just take care of in the usual way. Wow. Conundrum. Do we, the physicians, really know what we're doing? No, we probably don't. And it's getting late into the night, but here are just paper after research paper after research paper, some of which I've written national editorials about and such. Here's one for cardiac surgery, 5,000 some patients, the biggest medical centers in the United States, carefully controlled. Those patients who got blood transfusion had a massive increase in perioperative infection. What you're doing in Prescott will make a difference. And if you get one of these situations in the hospital, it affects you out of the hospital. The single greatest predictor of whether you live after heart surgery in the next year is whether you were transfused in the operating room. And whether you can go back to work, whether you have renal failure, whether you become a load on society with dialysis all the time, all is highly correlated with whether you're transfused or not. And so what do we as physicians learn? We learn it largely through this culture and lack of teaching that exists all over the place. The largest cause of death and morbidity for transfusion, according to Neil Blumberg, who's a very good friend of mine up at the University of Rochester, he says is immunosuppression. And we talked about that. That has to do with decreasing infection rate. And I agree. But I also think I've saved some lives with transfusion, but do I know that? Do I really know that, or do I just think I know that? because I've never done a study to say, were you going to die if I didn't give you that unit of blood? Yeah, in a gunshot wound in my hospital where somebody's bleeding out, yeah, they probably would. But other than that, probably not so much that I would know that.